Hello, everyone, and welcome to EULAR 2020. That's Frankfurt in the background right there. Well, I mean, we're simulating it. So my name is Tiffany Westrich-Robertson. I am the CEO of International Foundation for Autoimmune and Autoinflammatory Arthritis, or AI arthritis for short. And I am also a person living with rheumatic diseases. Non-radiographic axial spondyloarthritis is, I guess, the main one, and also a sprinkle of some other things, which we know is not that uncommon. And I have friends. I have friends at EULAR. Hi, friends.
Hi there. Hi there. I'm Deb Constien. I am a patient with rheumatoid arthritis. I've had it since I was 13 years old. So nice long time of having the this disease, and a lot of other little things sprinkled in there as well. So I'm happy to be here. Patrice.
Hi, everybody. My name is Patrice Johnson, and I have RA, maybe. I don't know anymore. Working on that. And I have some sprinklings too.
We're sprinkles. We're all sprinkled.
I think of ice cream when we say sprinkles. So that's a happy thought, right?
Maybe Kroger's, whatever those are.
I don't have ice cream, but I do have wine. And that is because this is, we are trying to make this as realistic as possible when we get together at conferences, which again, we are attending EULAR, the European League Against Rheumatism, their scientific congress, which was supposed to happen in I almost said Madrid. Wrong year. Flashback in Frankfurt, Germany. And so usually in the past, Deb and I have been the ones historically that go to most of the conferences. Sometimes we have others with us. But after a long day or a long couple days of attending sessions, we sit down, we relax over dinner and a little bit of vino, and we talk about what we've learned. And we're bringing you along with that. And we're bringing Patrice.
Yay!
I'm so excited.
Yes. So go ahead, Deb.
One thing about Patrice is, again, it gives a different perspective. Tiffany and I have been doing this for years, and we love that Patrice is bringing a whole new perspective for us too, and it helps us learn too of what we're kind of might be overlooking. So Patrice brings a great perspective to that.
Thank you.
Absolutely. And we're asking you to bring your perspectives now too, as we bring this session discussion to the table live here for you, live if you are tuning in. If you're not, and you are watching this after the fact, that you could also leave your comments, because we will come back and try to have a continued conversation with you. And let's just give you a little bit of background what exactly that we're doing here. So as we said, the EULAR Congress, which is one of the two main scientific conferences in rheumatology that happen annually, always is in Europe, and it happens to sometime in June usually. And then you have the American College of Rheumatology scientific meeting that happens towards the end of the year. We attend both of those. And at each of these conferences is where you learn all of the latest research that's happening in the rheumatology community. So it used to be specifically geared towards rheumatologists and researchers, but over the last few years, it has been a lot more patient-friendly, and particularly at EULAR, because the way that EULAR is set up is they have three pillars. They have one for the researchers, they have one for the healthcare professionals, and they have a third pillar for patient organizations. So there, it has been a little bit more patient-friendly than when we attend the ACR. But as we've said before, that will change if we have anything to do with it. But that's for a whole other discussion. Our discussion today, we are going to be reviewing two very specific sessions that we attended. One is Treat to Target, and another one is going to be Reducing Drugs, When and How. What? that one was a shocker to us when we saw that on the agenda. But I think we're gonna start off with the treat to target, and I thought maybe Deb, you could just give us an overview of what that even means.
Sure. As far as treat to target goes, treat to target involves a lot of shared decision making. So what that means is it's the doctor's opinions as well as the patient's opinions, and both are applied together to further the decisions as far as what they're going to come to. There are a lot of goals as far as what they actually go towards with this. Now, remission is the ultimate goal for most of it. Now that is changing a little bit. And I think Tiffany might talk a little bit about that later, but there's a lot as far as adjusting it. So if you look at the problem of how many joints are involved and things like that, and certain medications are added, and if nothing is happening towards making that better, then they add new medications to your list of medications or try different medications, which I'm sure most of us are used to that as far as how that goes. But what else should I hit on? I don't want to go too deep into the topics.
No, that's okay. I'll go ahead and just jump in with a little bit of the history too. So,
that'd be great.
So that's where we are today with treat to target. And This is not a new term. You as a person living with rheumatic diseases, if you are participating, very likely have heard this yourself, but you may not have really even realized what that meant. So Deb, thank you for giving us a little overview of that, because there are some very key elements. Now, treat to target came about, I don't know the exact year, so it's not, I'm not going to give you a complete history lesson, but let's say around a decade ago or so. Prior to this, the way that rheumatologists would address treatment was a pyramid. And so essentially it was exercise, take some over-the-counter medications. I know, Deb, you might be able to relate a little bit to this. Yeah. And then it was, okay, well, if you're not doing better, then let's move over to a DMARD, which is a disease-modifying agent. And we're typically talking about like a methotrexate, for example. A lot of patients are familiar with that. Now, you have to remember, too, it wasn't until the late 1990s where biologics came to market. But what happens every time something comes to market, it is an innovation. There's no research there to prove its safety or efficacy. So you're injecting yourself with something. It's got live molecules in it. I mean, it's scary. And so that goes on kind of that high top of the pyramid. And so it wasn't until you weren't doing well with DMARDs till you then went to the biologics. So as research started to demonstrate, wow, these things are great. they're really being quite effective for our population. The idea was, well, let's see here. We're having really great outcomes. The patients are for the first time in history are really doing well and getting better. Why don't we try to squish the pyramid and have an earlier intervention? And that's where it started again, roughly a decade ago. This is airing in 2020. And so since then, we've been going to these conferences and we're hearing all about the great research that's happening. Is it working? Is it not? And it seems that, yes, it is. And what it means is that early intervention. So
and that is truly where my history goes, because until the biologics came along, I was having a lot of structural damage. Since biologics have come about, the amount of disease progression has really stopped. Right now, I'm fixing what, the first 15 years or 20 years of my disease progression caused. So I am all about early detection and getting into the deep medications right away, because for someone to actually go through the process that I did, I was on gold therapy, for goodness sakes, way back when, and all that kind of stuff, which brings up, we've got a friend, Therese, who talks about it too.
Shout out.
Yeah, Therese.
I don't know if she's tuned in yet or not, but she probably would be talking if she was.
Yes, she would.
Not in a bad way.
No. But same thing, all these medications that they tried, they didn't have the same effect that the biologics have on, especially even on my disease progression.
And you both are disabled technically have a level of disability.
Yeah.
Whether it is formal or not.
Absolutely, because of everything. I mean, you look at my hands alone and you can see that. And my feet, I'm in the process of going through surgeries to try to fix those up. But again, they'll never be the same again.
Right. Patrice, did you have anything that you wanted to add? We don't want to dominate the conversation.
No, I'm on a steroid. So, but the world of biologics and early treatment have always been a factor. The very first appointment I had after it was discovered that I had something like RA, the first rheumatologist I had says, we're starting you on this immediately. But also I'm a little bit of a different anomaly because I was diagnosed later in life, which is, I wouldn't say rare, but it's different than people who have been diagnosed like 30s and in their 40s. Mm-hmm. So I was in my mid 50s. So it's kind of been a different story. And I have, I don't know if I will ever be on biologics, but for now, my medication is working and
it's holding. It's so great.
but that's really interesting, and that's great to mention. And I guess we should also preface by saying we are reviewing research that is from a scientific, largely medical community. There are some non-pharmacologic sessions that are there, but for the most part, they're medical, and we're talking a lot about treatment. So by talking about this, we are in no way, shape, or form suggesting what is better or worse for any one person, and that's the idea of treat to target. And in that session, one of the things that I didn't write this down, so I'm going rogue on this one. I'm not looking at my notes, but one of the things that I remember thinking was really cool about the whole treat to target is that it's really about making a decision of what your disease is going to look like 3 months from now, 6 months from now, a year from now. It goes so far away from that pyramid that we mentioned earlier, where it was starting with the exercise and the diet and the sleep and the over the counters, to we know now that research is showing that this method of combination, I should say, of therapeutics based on your disease presentation right now is the best. And that's why some patients will start on DMARDs. Some, depending on their severity, will skip DMARDs and go right to biologics. Some will have dual, the DMARD, the methotrexate, and the biologic, which actually I'm going to reference a study on that here in the next segment when we talk about reducing our drugs. But I thought that's just really interesting because you sit there and it's shared decision-making, like Deb said, talking to your rheumatologist about what are my goals in 6 months. And depending on what we want to achieve, they'll put on. And for you, Patrice, it wasn't biologics. That wasn't the right treat to target, but it doesn't mean that you are not being treated in that same manner.
Yes.
Right?
Yes.
So I think that's important to point out. So I'm glad that we said that because it's not, it doesn't, treat to target does not mean it's biologics. That's not the only way that you can treat the target. So I did want to bring that up. But there was some interesting research that they were showing. And Deb, you had talked to us a lot about the juvenile arthritis because the title of this was, I think, treat to target adults and children, or so they was definitely talking about a little bit of both, and then comparing them. Deb, will you tell everybody a little bit about the research for the juvenile?
Sure. As far as they were talking about some of the barriers to implementation with the treat to target in clinical practices, and they were talking about some of the like the reluctance of clinicians to actually perform formal joint counts with adults. And that was actually one of the things that I saw, besides where I'm reading now, but it talked about specifically with the adult patients. They found that it was harder for the practitioner didn't want to do formal joint counts with adults as much as they did with the juvenile. They also talked about the parents. Now, the parents, they were making the assumptions. Parents are the ones reporting to the clinician or the rheumatologist for the children. And so some of these children are only like 12 months old, 18 months old. So they're not verbalizing what hurts or anything like that. So, I mean, you've got the parents making their choice on how they want to report back. And it's, basically how the parents are reporting it. So that is interesting in itself, I find, because, parents are really good at reporting that, but again, they might be also taking their own, version of what's happening. So you don't know exactly what's going on. Let's see. They also talked about, for the juveniles, that there was a lack of guidelines on optimal tapering of medications and withdrawing from treatment after achieving a inactive disease. So the patient isn't having as many symptoms on their medication. So there wasn't necessarily a lot of guidelines. There are with some of the other diseases in adults that they do have guidelines for that now, which again, like Tiffany says, what? Because you don't hear about, the medications going away. So we'll talk more about that later. But that was one big thing. And they also talked about the comparison of the pediatric and the adult definitions. Now, one thing in particular was for adults, they talk about a tender joint count of less than 1. And with the for the juveniles, they called it active joint count of 0. So, that is interesting in itself, because again, you're talking about active joints versus tender joints. So, that
I tend to think that when my joint is tender and hurts, that it is active. So as a person living with these diseases, I just would like to explore more clarification on that.
Yes.
Personally.
Exactly. Oh, exactly.
Maybe I'm using the wrong terminology when I'm speaking to my doctor. But I found that interesting too. Something else well, first of all, let me back up. I forgot I was going to mention this when I was talking about the history. So some of you may have heard this phrase before. You might have heard ACR 20. Or ACR 50 or 70 or 90. And again, that was a term about a decade ago. It was thrown around a lot. And what that really means is ACR stands for the American College of Rheumatology. And when they started doing the research for treat to target, or to figure out if certain aggressive treatments would help with to have better outcomes and possible remission in patients, what they would do is they would compare your improvement in percentages. And so ACR 20 is 20% improvement. Yeah. 50 is 50%, 70%, 90 is 90%. So those are the levels. And I actually remember doing a presentation, and it was about 2010. So it was about a decade ago. Okay. And I was doing a presentation to a pharmaceutical company, and they were asking, what do we want? Because they use that criteria in clinical trials. Because if a drug is showing that it has 20% efficacy, then it's showing improvement. It's showing a level of improvement. And I remember saying, I don't give a crap about your ACR 20. And the whole room kind of went, wah, wah. And I was like, no, I'm just saying, what about ACR 50 or 70 or 90? Like, yeah. I get it. You have to start somewhere. And back then, that was a good target. It's kind of like we're talking about treat to target, right? We said, try to improve in this month. And then, you go to the next month. But Yeah, I just said to him, we got to aim higher than 20%.
Well, that kind of goes back to the COVID thing too, with that just kind of makes me think back to COVID with what they're shooting for the vaccine. I mean, they're talking about only 50% efficacy. And to me, 50% just seems like so minimal. I feel like, okay, we need to shoot a little higher than that. But again, don't know. Yeah. Now, Patrice, you had actually said that you had just learned about those percentages. What did that mean to you?
Well, I wasn't quite sure because I read Tiffany's note and I'm going 20. So when I went on the American College of Rheumatology webpage, and it's the improvement levels. Mm-hmm. So I guess if you're having, a bad flare for months, weeks, you're in like the 20%. Or maybe for me, like currently right now, I'd probably say I was in maybe the 70. And of course, that could all change next month. We don't know. But I thought that was really interesting. But I was also trying to figure out, how do they measure that? And maybe that's a topic for another day.
Well, no, I can actually answer that. So what it's specific, and Deb actually had a couple slides on that. And what that really means, yes, it does mean improvement, but it's not so much about the improvement of how you're feeling necessarily, like, oh, I'm having a good day. On a scale of 1 to 10, today I'm a 7. It's not quite that. What it mostly is for is tracking the efficacy of that treatment you're on. So if you go back to your rheumatologist in 3 months, and when they first, how you go in the rheumatologist's office and they have you fill out those forms when you first go in, if you scale 1 to 10 today or this week or this month, what were you? So those are disease activity scores essentially. And they're measuring how well you're doing. So not just today, but generally. So they do have measurement tools. And then they also will combine your blood level, inflammation. So you might hear that as your ESR or CRPs, all these fancy acronyms where they're essentially measuring the inflammation levels. So all of that is clinically showing how you're doing. And that's really when you're talking about the ACR 2040, it's mostly in comparison to how you're doing on your medication. Mm-hmm. And that's why they use it in clinical trials. So in the clinical trial, if you were out on there for your medication, they would be testing all of those clinical features. You'd be filling out those forms, you'd be getting your blood work. And then they would say at the end, 40% of the people in this trial achieved ACR 50. 20% achieved whatever. And so that's how it goes. But that's important, I think, as patients to understand that term or those terminologies, because that is so ingrained into everything about our treatments. And we should be able to at least be able to understand that on the same level, I think, as our doctors. And then I see Agreed. we got to give a shout out to Therese. Therese, that's for you.
Yes. Indeed.
For you.
I wish Therese could actually tell the story, but I'm going to tell the story for her. So we were talking about the gold treatments, and further along, when she went in for a doctor appointment, she found out she actually had gold deposits in her breasts. Mm-hmm. So she said she had 24 karat boobies. So again, funny.
Therese, we miss you too. We miss you too.
Yes, very much.
So one of the things that when we're talking about treat to target, and we'll go back to the JIA, the juvenile.
Yeah.
I just personally thought this was we say interesting a lot. I got to get on the thesaurus and grab some more words because I'm overusing that. But when they were talking about the specific line items, if you will, on the goals for treatment, it was to control the signs and symptoms, prevent structural damage, avoid comorbidity conditions, growth and development, quality of life, and social participation.
Yeah. So, I mean, are you able to do activities like everybody? Like they don't ask us all that time.
Right.
You know? I know.
That's exactly what I said.
Maybe they say that they can go skiing or something like that. I mean, not that
I get it. I completely understand how when you're growing up, I mean, and Deb, you were there. You were a teen when you had onset. So I can see where that is for anybody, that's a huge adjustment period in your lives. And I had onset at 37. So it was an adjustment for me as well, but I had already established my life. So my social issues were more about who am I now, not who will I be.
Right. And I mean, I remember, I was third chair flute out of 30 flutes, and that came to a crashing halt. I was a competitive swimmer, and I became the manager of the swim team because I couldn't, with fatigue and everything else, I just couldn't. And I was in so much pain. I remember I was freshman in high school. So I remember in high school, I never wore shorts. Because my knees were like huge, and I was embarrassed by that. So I always wore jeans, and everyone's like, why don't you wear shorts? It's hot. And I'm like, yeah, no. And I could never squat down. So I was always either sitting or standing. I couldn't squat or get down to the floor or get back up, for that matter. So I remember all of those things and the adjustments, and, coming to terms. I was, a full-grown adult in probably only maybe 10 years ago. I kept my flute until then because I couldn't give it back or give it away or anything. I just kept it. And then I tried to put my fingers back on the keys, and my fingers didn't line up at all. And seriously, I couldn't physically even put my fingers on the keys. So at that point, I finally made peace with it and gave it to our pastor's wife and her daughter. They both played flute, but were never able to play together. So that actually gave me some personal highlight in giving away. And I was ready to.
Yeah. Well, that was the timing. I was going to ask both of you. I'm just curious. I mentioned that list. So I know that's what is there right now for juvenile idiopathic arthritis. And it was somewhat different for adults. Like I said, the social, my knowledge wasn't on there. Well, if you had to pick, and anyone who's listening as well, if you were going to say treat to target, what do I want? What do I envision for me 6 months from now? What would you want on your treat to target list?
See, I'm past. I'm sorry, Patrice, I didn't cut you off, but I'm already way past the structural. I don't have the structural. I mean, the structural damage is already here, and that I can't even count that anymore. I would like to avoid more comorbidities and control signs and symptoms. So I guess that would probably be one of my things, I think, for quality of life in general, maybe.
Yeah. What about you, Patrice?
Same thing. Quality of life. I love to travel a lot overseas. I'm hoping I have a bucket list of places to go, and I'm hoping I can, of course, COVID is going to take a huge chunk out of my travel plans, but once that's get all straightened out, so I'm hoping I could get everything off my bucket list, but as well as the comorbidities. I mean, I have a few. I mean, a lot of them were a complete surprise, and I will just share real quick. In 2018, I was discovered with severe hearing loss, which is a comorbidity of rheumatoid arthritis or something along that lines. I never would have imagined that, but I knew I was having trouble hearing people on the phone and watching TV, and also people speaking. So that just blew me away when I was at the ENT's doctor's, and he showed me my scores, and it was amazing. So it's like, what is next for me? And I'm a little bit older than the both of you, so I have to factor in my age as well, and pushing forward. I mean, I hope I can continue to do what I'm doing right now, but the unknown, I don't like unknowns. I'm just one of those person, probably go along with everybody else, but I don't like unknowns. So that just drives me crazy, but I guess that's just life. But
you know, something that I want to bring it back to the research here, and that's kind of what we want to do here is these are, you know, we're patients, we are reporting research, but we're also talking about how the research is relevant in our lives, because that is extremely important part of continuing research. And so I'm going to bring it back to a little bit of technical again. And one of the things that when they talk about the treat to target and what we just mentioned, these goals for treatment, these are really outcome measures. So what that means is they are specific line items that can be measured, that you can tick a box and say, we achieved that. And the way that outcome measures have changed over the last several years has a lot to do with the group that Deb and I are both affiliated with. And that is OMERACT, which is Outcome Measures in Rheumatology. And they started in 2002, bringing patients to the table alongside researchers, and they create domains, or these kind of, it's called an onion. So it's like the most important thing to a patient's in the middle of the onion, and then the secondary, and then the tertiary, and it goes out from there. And so they are responsible, for example, for adding fatigue to rheumatoid arthritis as a measurable outcome, because patients were like, hey, it's kind of big. That sucker's in the middle. And so that's, the good thing about the treat to target, when they're saying shared decision making, and they were creating these outcome measures, or these domains of controlling symptoms, structural damage, avoiding comorbidities, growth and development, quality of life, social participation, those in some way had to come from the patient or the parent saying this is an important element, because I don't know why social participation would have made it if it wasn't.
Yeah. Again, travel, like Patrice, I mean, that is a huge thing. And, being social, that's a social thing, again, being socially participating in life.
And go ahead.
Yeah. You can also be at home and, participating in life, but you could also be on the couch covered with a blanket and not participating in life too. So.
But, I think that if somebody would have asked me when I very first got diagnosed, what are your goals? And I could see a list and it had all of these things in it. I think when I first got diagnosed, I wouldn't have called it social participation as much as social well-being, maybe, because it was that whole moment of, who am I now? Oh my gosh. Do I have to, I changed careers. Like, I don't even know myself anymore. So it is a psychological. And I just think that recognizing that, I wouldn't have it on now. So I think that when we think about treat to target, and we're starting to evolve into this individualized and in precision medicine and personalized treatments, we should also be thinking about the phase that a patient is in, because that might not be relevant. Now, I could see where it would be for kids, regardless of age. But I'm just my point being, food for thought as we move forward and start getting more and more involved, that's something important. There was something else. You already mentioned it a little bit, Deb. You were talking about the differences between the pediatric and adult.
Yeah.
And you had mentioned the active versus tender and swollen joint counts, but that also, that is listed on the comparison of pediatric and adult definitions of remission.
Right. That's true.
So let's kind of end this treat to target part of it and ending in kind of remission. Let's talk a little bit about that, and then we'll go into the last leg of this.
Sure. So starting to talk about like remission and what we think of remission as.
Sure. Go ahead. So
sure.
Well, first of all, Deb, you had a list of things that, which has a lot of different things of remission. So let's start there.
Sure. So some of the definitions, and this was actually a list that Susie Palmer, shout out, she put together, and it was related to a lupus discussion. But one thing in particular that Susie pointed out to us was that there were so many different definitions of remission. And, right here alone, it talks about complete remission. So complete remission is there's no clinical or serological activity. So that means through your your lab results. Your lab results come back fairly normal. And also, let's see, they talk about no corticosteroids and immunosuppressive-free patients. But they do say that the Plaquenil is allowed. So for complete remission. So for a lupus patient, it would mean, so no other medications, and you're under, so you're having no swelling, no tender joints, and you're doing really well, but you're still allowed to have your Plaquenil. There's another one, clinical remission off of corticosteroids, so off your prednisone and things like that. Another one, clinical remission on corticosteroids. And
I saw a clinical, a remission, an MRI remission.
Yes. Again, so many different kinds of remission. And again, I've been having this disease for 38 years, and I have never been in complete, total remission ever in all these years. And I don't think I ever will. But again, it's the difference of what remission is to that person. And I think my definition of what remission is still being on my medications, but not being in serious pain and being able to do activities that I want to do, like weed my garden and clean the house and things like that. Stupid stuff, that kind of thing.
Yeah.
What about you,
Patrice? What about you?
Well, I guess it's kind of strange, in 2017, that whole year. Now, my rheumatologist never mentioned the word remission, but at the beginning of the year, I had my blood work done, and the results were going in the better direction. Then in a couple of months, I had it done again, and they kept going down and down and down.
Down as in like in a better direction?
Better direction.
Okay.
That whole year, I had no pain. And in the fall of 2017, when I saw my rheumatologist, I said, I've seen the results online. What does this mean? And he said, well, he kind of danced around the whole thing, but he said, I don't know what to tell you. He said, what are you doing different? I said, nothing different. And he said, well, he says, I have no explanation as to why your test results look like you do not have rheumatoid arthritis. I was blown away. But throughout that whole year, and this probably will lead into the next segment, is I began to taper off the medication. So, and I'm still on that lower dose as of now, but that was for a whole year. How do we explain that?
Yeah.
Well, I did want to also bring back to just about the research that we were talking about here, and the treat to target outcome measures, and one of the things when we're talking about remission in particular is that there is the disease activity score. We sort of mentioned it before, but the disease activity score, if you think of a scale of 1 to 10, and different parts of your disease have an assigned number value. So, for example, in the research that we were watching in the session for Treat to Target, they were talking about juvenile idiopathic arthritis. Fever had a 4 because they feel that is such a diagnostic, recognizable feature that it deserves higher point values. So what happens is there's different disease activity scores, and we don't need to get into all of those, but it's just like there's many kinds of remission, there's many kinds of disease activity scores. And the real thing for us as patients to understand is they're numbered. And so you have your disease activity score, if it's on a scale of 1 to 10, a lot of, when you get into that under 3, like you get into the 2.6, 2.5, that's when it's looking pretty good for you. And then they consider clinical remission as 1.6 or under. So, that could mean like Deb was talking about the different, there are different criteria for what remission is, and just even children and adults, because basically the one for children is very strict. No joint pain, no serious, all your lab work is negative. It's very strict. Whereas it's a lot more lenient for adults, which, why? I don't know. Is it because of delay in diagnosis? Is it why is our remission not 0?
Right, exactly.
Not sure about that. But it is something to understand that on that kind of 1 to 10 scale. So it'd be interesting, Patrice, when you say, well, you were able to taper off, my guess is you were in that 2, range probably.
Right.
And if a doctor says you're in clinical remission, what they're really saying is your disease activity level is 1.6 or lower. So that really begs the question, what is remission? So clinical remission is one thing, and a doctor can say you're in remission, but if I'm still feeling like crap every day, I'm not in remission.
Do you know what? Rosemary just made a comment, and she said, I like the simplified terms of drug-induced versus drug-free remission. My understanding is that drug-free remission is pretty rare, but I could be wrong. That's a great point. And other words that are used for remission. So thank you for pointing that out, Rosemary. That's a great point too. And thank you for joining our conversation. And another thing Therese said, she had early diagnosis, but she said she just wanted to be able to brush her teeth and brush her hair without pain, and just wanted to live again. You feel that I'm, feeling alive. And I know Therese has lots of young grandchildren that, again, that's got to just take a toll too, but you push through too. That's not going to stop us from, doing what we absolutely want to do.
No, that is very true. And I like that comment too. Thank you, Rosemary, for saying that. And that's very true. We're going to cover this a little bit, where it talks about what drug-free remission is versus clinical remission in this segment. So what a great segue. that we're going in. So good job, Rosemary. We didn't even plan it. It's just we're just right there. So the wrapping this up, going into the other session was called Reducing Drugs, When and How. Yeah. And literally I went, what? Just Deb and I have been to these conferences for years, and never have we seen a session that was talking about getting off of our treatment.
Yeah, taking the medications away.
It was always about increasing, and let's be aggressive, early intervention, let's be aggressive with these. And the subtitle to this, now that we know treat to target works, research has to move into when it's time to reduce. And that was really that's really what they talked about. Yeah. In this.
Yes, for sure.
And I wrote down a quote that the doctor who gave the session, literally, she started and said, for years, we've been talking about increasing drugs, increase. But that work has all led to positive outcomes and the potential stopping of disease. Now it's time to talk about when to remove the drugs from the patient. And, it was, Deb's gonna share a list with us, because what this session, it started out, the doctor was talking about some of the reasons to reduce treatments. I just mentioned the main one. And that was because we've talked about a decade ago is really when this treat to target came about. And they realized, let's get rid of this old pyramid of you start at the bottom with, some over-the-counter stuff, and then we'll move you up. Biologics are sort of the last resort. They got out of that mentality. They said, nope, let's increase, like she said. Mm-hmm. And if we're aggressive, what's going to happen? She did mention a couple things about some people had pushback, which makes sense. I mean, you're scared and, safety. But what has happened is research has shown time and time again that early intervention with disease-modifying agents and particularly biologics, which we have some research to share on that, it has the best chance of then getting the patient to a point where they are able to remove medications, at least for a certain amount of time. Mm-hmm. And one of the reasons that that's important, as we all know, is that these medications are very expensive. Yeah. And, they can create side effects, but mainly, we need to make sure that we're being healthy and the healthcare system can maintain other people as they get diagnosed and they can go treat to target. And so I wanted to preface that, but Deb is going to share a list. And what this list is when they decided, let's start the research on if a patient can get off of their medications or not. They found it interesting. So I'm going to throw the word interesting out again.
Yes, they used it.
They said, well, it was really interesting to us because they had pushback and they kind of thought, wow, patients are going to be excited. They can get off their treatments. And so they conducted a little research to start off their recruitment. Deb's going to share a little bit of that.
Yeah. So it was entitled RA Patients' Beliefs and Fears on Stopping the DMARDs, which are the disease-modifying agents. So these are what the patients reported back. It's not possible. It's necessary in case of or avoid adverse effects. Only after slowly tapering during low disease activity. Oh, DAS. What is it again? Disease activity
score.
Score. Thank you. I was totally blanking on it. Intense monitoring required for that. A good sign, it means the RA must be really well suppressed and return to normality. Scary, because there's always the risk of flare. And underneath that, it says, I expect to fall behind, may take a longer time to recover, may need more medication. Medication might not work again, or will develop damage and irreversible loss of function. So that is what they talked about as far as what they found out. And I can completely relate to that. I've never been off of medication. And the thought of that, my doctor wants to continue to taper my prednisone in particular, just, that in particular. And I'm at 6 milligrams, and which is not a lot, but I've never been below that number. And she still wants to, keep tapering. And in my research, they always talk about what's your adrenals might fail during that time. And that scares me. And the thought of flaring, I've always had, things or activities that I'm like, why would I want to, go through all that pain and flaring for a long period of time? And if they go back to, putting me more back on prednisone, will it take a higher amount to get me back under control? And all of those different theories in my own head that, makes me nervous. But again, I'm on biologics. I'm on the DMARDs. I'm on steroids. I'm on sulfasalazine. I'm on tons of medication. So I'm on a lot of medication, and it still spooks me a lot.
So let's role play here.
Yeah.
So I'm your doctor.
Yeah.
Hey,
Hi
how you doing today, Mrs. Constien?
Yeah. Doing okay so far.
Okay. Well, we're thinking about possibly reducing some of your treatments and getting you on your way to a place where maybe you wouldn't need as many. You've been doing well for the last 6 months or so. What are your thoughts?
My reality side says that's probably a really good thing to work towards, but then my patient side, it freaks me out.
So so would some of your responses be the same of the responses that they saw in their survey?
100%. Oh, 100%. Yes.
Which ones in particular would stand out to you?
The scary because of the risk of flares, the falling behind, with your medication, and then it taking longer to recover. I don't want to give up my time, because my time is important to me. I've got a 21-year-old and I don't want to miss games. I don't want to miss anything. And let's see, medication may not work again. That freaks me out, because I'm like, I was at a good spot. Why would I want to poke the bull or whatever they call
the bear?
Poke the bear. Yeah.
Well, you can poke a bull too.
Yeah, I know, that's true.
Probably going to have similar responses if you poke either one of them.
Exactly. So, that does freak me out. Or, again, loss of function. What if that I mess with that and it permanently goes away? Like, even less function of my hands, and I'm dropping even more things than I typically am.
Mm-hmm. Hey, what about you, Patrice?
Yeah.
That year that I was talking about, there was no definition, or at least I didn't hear a definition. Now, supposedly, of course, I know a lot more today than I did back then. That was 3 years ago. If he had said, let's take you off this medication and see what happens, like Deb, I probably would have freaked out. And he's since retired, and my current rheumatologist, when I saw her earlier this year, she had said, let's get you off your medication. And so I looked at her and I said, well, what's the plan? If it doesn't work, what's my next? Of course, I ask a ton of questions. She just looks at me like but that's a story for another day. But so, like Deb said, suppose I did go off completely my medication, and maybe let's say it worked for a week, and then the next week,
tank,
all heck broke loose. Let's say I had my bottle of pills there and I couldn't get in to see her, and I'm just going to take what I normally would take, but now it's not working. Where do I go from there?
Mm-hmm. Mm-hmm.
It's very scary.
Well, I think that, and I saw Deb had typed in, for those who are tuning in live, if you have, we'd like to hear your opinions on that too. I mean, what would you do if are you even on, biologics or DMARDs, or, I guess that obviously matters too. But when, I guess the follow-up question then would be, when would you feel okay? I mean, I guess my own personal, I would be, even if I felt that my disease was somewhat under control. And see, the thing with me is I have never, ever, ever had inflammation markers in my blood, ever. I've always, every time it's always, your blood works perfect. There's nothing wrong with you. I mean, it always. Yeah. So I've really had a time trying to even have someone believe me. Now, we're 13 years in, I just now start getting some swelling in certain areas. But before I didn't even have that. So it was really hard for doctors to believe me when there was no damage, there's no inflammatory markers, so my disease activity score for the most part is low, because it might add up in numbers based on the reports of how were you functioning this week or this month that we all fill out when you're in your doctor's office. But there's a lot of trust and belief that has to go into a doctor believing you if you don't have those. So I think I know that I'm able to do a lot And I think that if I was doing pretty well, I think I would still want to stay on them.
Yeah. You know, Rosemary.
For now, and it's not research. It's not because I think, oh, well, I know that the research is, I have it right here.
Yeah, I agree. Yeah.
That's not it. It's just, I am so scared of getting to the point again where I can't
do things.
I can't do things.
Yeah.
Exactly.
Rosemary said that she has very similar concerns and she's on similar range of medications. She understands the theoretical reasons for tapering, but which I totally get the ... I feel you, Rosemary. And Kim, welcome, Kim.
Hi, Kim. She emailed me and said she wasn't sure she was going to be able to come. So
yeah, she mentioned that, yes, rheumatologist wants to stop her son's meds in October, and he's really anxious. I get why. I get it. He can't stand the thought of becoming an immobile teenager with swollen knees and horribly large plaques. I understand. And Kim also said he's on biologics as well. And Rosemary said it sounds similar to the current trends towards tapering pain medications like opioids. If patients are managing their conditions responsibly and under supervision, why mess things up? And again, I totally get that too, because I am on a fentanyl patch, and I've been on a fentanyl patch for probably 15 years as well as all those other meds. And thank goodness I have not gotten much pushback, but that scares me big time. And I was that teenager. I was a 13-year-old with the big knees. I don't know when you caught on, Kim, but I was telling that story. I was diagnosed at 13, freshman in high school, and never wore shorts or skirts or anything that would ever show my knees. I avoided that like the plague. So thank you, ladies, for jumping in there and giving all of your opinions. Because again, it's scary. I get it. Because again, the scientific side of my brain tells me, well, that makes perfect sense. You're under control. And I mean, I get that. So it looks like your son is 15. So yeah.
And I would have to say, and again, we're not giving medical advice or anything here. Opinion. Just again, because I don't, and reiterating some of the things that we talked about a little while ago. And that is just this whole concept of treat to target being a shared decision-making situation. And that shared decision-making between the parent, the patient, and the doctor. Yep. Saying what is important to your son at 6 months, at 3. I mean, we already saw some of the things we had talked about, just those outcome measures or the things that are important in the treat to target. And some of the things that were mentioned in juvenile idiopathic arthritis specifically did talk about social things. So I think just not be afraid to talk to their doctors about their goals and their fears and their concerns, because what I learned from listening to the session, and we do this is just a great way to explain this. What we do as an organization, as a nonprofit, our mission is literally to help other patients like ourselves to have a voice alongside other stakeholders as equals. So we all sit at the same table, and we are able to learn from each other, have conversations that will allow us to solve problems that impact education, advocacy, and research. So what I heard, even though I was sitting at her table, I wasn't able to talk to her, but that doesn't mean I won't reach out to her. but what I learned was she started this with that survey that Deb mentioned. Yep. Literally saying she was shocked because she thought that the patient, when they said, hey, it's time to taper, that they would have been exciting.
Yes.
And some of the reasons she said that was, wow, you wouldn't have to remember to take your medications anymore. And I thought, well, that wouldn't be that big of a deal.
Exactly.
But no, the doctor's mentality.
The cost of medication too. That was
the doctor's mentality was like, wow, this is going to be exciting news. Our research has shown that you can do this. Wow. But they weren't thinking about all these fears and all of these realities that we are thinking about. And so the point of saying that is to remember that each stakeholder, patient, rheumatologists, we all are seeing, like, they're seeing this exciting research. So they're probably, the doctor may be just really excited, like, wow, this is looking good for you right now. Maybe it's time to reduce. That's the time to then, there's nothing wrong with saying, you know, we understand how treat to target works, because now you do, and and that it involves this decision making, and that there are certain outcomes that are really important to me, to my son, and we want to make sure that we feel comfortable before tapering off of anything. And my guess is the rheumatologist is going to be completely respectful to that. But I think part of it is the doctor is thinking, this is exciting news. And we're like, not so much.
Yeah, exactly. Because again, it's about, you know, the quality of life. Because I remember being that 13-year-old freshman in high school, and it's a scary time. And you don't want to be different than your friends. And you don't want to be like what she said, you know, the thought of, you know, your teens standing out and being immobilized. I was taken out of gym classes. So again, I wasn't part of the gym classes, but you know, it sucks being different. And you're trying, I remember I was given permission to use the elevator. No student was given permission to use the elevator. In 4 years, I think maybe once I used the elevator, because I'm like, I'm not gonna, you know, be different. I don't want to be different than anybody else. So I remember that clearly.
There was something else too, as I'm looking at the research here. So they were talking about, you know, doctors have their concerns as well as patients do about side effects. So they also did some research and presented it on the percentage of chance that these side effects would happen to you. The liver damage, cataracts or infections, maybe from steroid use, you know, the liver being from the DMARDs, the methotrexate type of thing. Patients reporting not wanting to take methotrexate due to nausea, hair loss, upper airway issues. That does not shock me at all, because I stopped taking methotrexate because it wasn't as much as the nausea, but it was causing these terrible ocular migraines several times a day. And so the side effects were too much for me. But their point of showing us this was to say, again, these are side effects that doctors are concerned about and patients are concerned about. And even though that they're low percentages, it's something to think about and maybe a reason why you might want to end up getting off of drugs. So they were showing it. You got to remember, the session was designed for rheumatologists. So, you know, they're giving the data to show why it can be encouraged to reduce the treatments. But I thought one of the things that you both mentioned when we were talking about reducing your drugs, you both said you don't know if you'd be okay with the steroids. And that's just, I think that each one of these medications needs to be considered instead of this whole group, this whole thing as a whole. And sort of what Rosemary mentioned earlier about, okay, well, we've got all these different levels of remission. And is it, you know, drug induced, you know, remission? Is it no treatment remission?
Right, all the different kinds.
There's all the different kinds. And I think that also can factor out into the different versions. Cause like if you were on, like you, Deb, you know, I know that you have no desire to change any of them. And then we've got Patrice. We're like three in a spectrum here, because then you have, I'm on biologics with no methotrexate and no prednisone. And so it's just biologics. So we're all at a different thing. So I have no option. Like if they said taper me, all I got is the biologic.
Yeah.
You know, I mean, there would be no
in between.
Option. There would be no in between, unless I went down to just methotrexate or DMARD, which I already found intolerable. So, so my reduction would be different. But the point being that it's great that the research is going on, and it's exciting that we've gotten to the point of showing that early aggressive treatment works.
Yeah, that's absolutely
wonderful.
Yeah.
But now, as
looking at,
Go ahead.
Yeah, the one thing I'm looking at, because it talks about, overall with the tapering, it talks about always try tapering the oral glucocorticoids, which are the prednisones and things like that. Why? Because the cumulative dose is dependent on adverse drug events. And when it doesn't give a clear time as far as when that would be appropriate, but how is less than 3 months, an individual approach. So the one thing that they also talk about is it could also suppress disease activity. That's what prednisone and things like that do. Always try to taper and preferably stop the DMARDs with, now what it talks about, the TS and the B kind. Again, those are different kinds of DMARDs. It talks about why cost reduction, which again, if it's not individual medication, lab surveillance, like all the labs that you have to have, and is it safe to stop? And it talks about when, if you've had a prolonged remission of greater than 6 months. And then it talks about to taper half doses and double the interval in between. So if you were to take it like on a weekly basis, they talk about doubling that to every 2 weeks. And the other consideration of the other type of DMARDs is if the adverse effects outweigh the benefits, discuss the patient's benefit versus risks that are involved with that, which is good that they're considering the patient's thoughts there. When prolonged remission after stopping the other kind of DMARDs. So these are the synthetic DMARDs that they're talking about in this one. And how is slowly by every 2 months, flares should be recognized and treated rapidly if the patient's having a change. So yeah, I found that information really interesting because they give, ideas as far as how to do it. But again, it's personal on that. Mm-hmm. I think it depends on the person. And, for Rosemary Kim with your son, again, it's definitely back to, what is going to be best for him in general at the age he's at, for sure. And Therese said, no, I wouldn't be okay with resorting to steroids. So taking steroids in general, are you taking steroids, or you would not be okay in resorting to decreasing your steroids? I wonder what that meant.
Well, so so we'll wait for her response on that. But one of the things I think that's also come out of this conversation that we're talking about is realizing research takes time. Mm-hmm. And this was a theme that we talked about in COVID. And, it's about, this research is there. It's legitimate. It's showing that that it is possible. So that's great news. But we also have to remember that, and we'll talk about this more next week, is that treat to target, what it started as a decade ago, which was, let's prove that early intervention works. They proved it.
Yep.
Now it's moving on to precision medicine. And everything is about the individual patient, the individual, therapies, because they're recognizing that all of our diseases, including rheumatoid arthritis and psoriatic arthritis, which, I know it's been a big pain for a lot of patients for a long time, that it's, that arthritic component, but that these diseases are being recognized as multi-symptom. And again, we'll talk about that a little bit more next week with precision medicine. But I think it's important to take away that this discussion today is, even just talking amongst ourselves, it's going to be really important for researchers to understand that an overall umbrella window of recommendations for reducing treatments is not going to work entirely. It's a good start, but we need to branch it out. So, hey, we'll reach out to these researchers and we'll, give them our feedback, and we'll definitely invite any researchers that want to continue conversations with the patient population, because I think that this is all really great information, so that when they do set up the study. Speaking of which, I did want to mention, okay, there, Therese said, resorting only to steroids again.
Yeah, because I know you had a lot of like issues with steroids. I remember that, and you made jokes that your husband was like would want to sleep in another room from you and stuff like that, because it just how it affected you. I remember that steroids don't play well with you.
Yeah, and all of that factors in. You know, you can't just look at the clinical responses or the disease activity score on, let's say, steroids. If it's something that's turning you into, Therese the tornado, then, that's an issue, know? So all of that needs to be considered. So just very briefly, the research that we've been talking about, they did cover a couple different studies in particular, and that they conducted, the woman who was doing this. So they ended up finding patients. They had them. They got through the fears. They said, all right, let's check this out. Well, what they have to do in a lot of clinical trials, and this does create biases. And what biases mean is essentially it can't, for some reason, be maybe relatable to all, because there's something that's preventing it. And so in this case, it would be if there were some early patients that have never been, on treatments, in that case, then it could be different than somebody who's had disease activity for, say, 10 years. I don't know, because I wasn't able to go and look into the research in specifics on the demographics, like, is this a new person? Is this a biologic naive person, et cetera? Mm-hmm. But I can tell you that the results were very, very promising. So essentially, I'm going to break this. I'm not going to give a complete report. Basically, what they did is they had different samples, different segments that they broke down. So they have a group that is just on methotrexate. So they give them methotrexate, and they're going to watch how their disease progresses, their disease activity score, for 3 months, 6 months, 12 months. Okay. Then they have another sample group that has methotrexate. I always mess up the sulfasalazine. Yes, I that one is a tongue twister for me, and steroids. And so that one, that's where they start on that group. And then the other one is they start them with methotrexate and biologics. Mm-hmm. And so they measure them over time. And what happened was the people who were just methotrexate had a very low positive outcomes. A lot of it was they just couldn't tolerate it. They dropped out. They didn't want to be on it. But they measure their disease activity scores. And so they were not so much controlled after the end of this. Then you have that middle group, and there was a lot of shift between the medications. Like, this is where, we're going to adjust this. So that was a big adjustment period. And then what happened with the ones who started with the aggressive treatment, treat to target early, which is the whole premise on how reduction really will work best, is they were able, after, and I just don't have the months, after a certain amount of months, I'm sorry, I don't have it in front of me, they were able to go off of the biologic and just stay on the DMARD mm-hmm. for a significant period of time. Mm-hmm. And so that is really promising. There were some things to point out. They noticed that the patients that tended to do better first of all, Deb, you had said something about, I'm scared to go off my biologic because what if I start again, it doesn't work as well. Yeah. They found there was a good response to starting up on the biologic again. So that did not seem to be an issue for the patients that needed to do it. So that's good news. And then they said those who seemed to have the best response who were treated with the biologics early were not smokers. I've been hearing a lot about smoking lately, especially with COVID and everything. Were not smokers. They had ACPA negative, which is an antibody. I'm going to butcher it, but I'm going to try. Anti-citrulinated. Citrulinated. I said it. That's right. Protein antibodies, but ACPA for short. And they did not they were negative for those antibodies. And so that is important to note, because that is an individual protein. That's something in our body that researchers are starting to look at, these biomarkers, so that they can start to target treatments better. So the treat to target has moved in, as we mentioned, to this sort of precision medicine and understanding the individuals. So they didn't just do this research to say who had an improvement. They also said who had the best improvement. And so understanding that particular autoantibody in certain demographic of patients, and that they responded better, that's going to be really important to know, especially when we're trying to make the decision, right, to get off of them. So maybe that's something that a doctor could test. So I just wanted to throw that out because it was about precision medicine, and I thought that was important to note.
Yeah.
But most had been able. There were 50% of the patients who tapered off and kept on the DMARD did end up flaring around 12 months. So that's 50%. But then they went back on the biologic for 3 months and ended up doing well, and were able, I believe, to come off of it again. So
interesting.
Yeah. So the research was showing. We've got a lot more, but again, we can talk more about this for at a later time in more detail. But that's the bottom line. That's the gist of it. And I did also want to mention that they didn't show it, but they mentioned it. So I do want to look into it a little bit. But they did say that they did some kind of financial analysis, and that the group that started with the aggressive treatment with the biologics to the DMARDs, when you looked at the overall long-term healthcare costs, because they were the ones who were able to essentially achieve some sort of clinical remission or close to it, that the long-term healthcare costs with those patients were lower.
Interesting. Okay.
So one of the things that, depending on where you live, whole other show, but the whole idea that our healthcare systems, regardless of where you are, have sort of this pool of money and has to be dispersed and shared between all people. And so there's a lot of discouragement to not get on biologics or get on the expensive ones, because people only look at the line item number at the end of a calendar year, instead of saying, well, 5 years from now, it's going to save X amount of money. It's just, that's not looked at that way. So,
right. Kim did mention that for her son, she said more than one doctor has mentioned that they are hopeful that after puberty, medications won't be needed. And she says, I can't find anything to that point, but perhaps it's just a hope people will share more about that. That's a real interesting point, being a JIA. Also, Rosemary made a comment that she's been on steroids for many years with different doses. She was on 15 milligrams for several years, and that was the main thing that kept her functional. And it did result in her getting type 2 diabetes and cataracts in both eyes. And she has since tapered down to 8 milligrams and has stayed there about for 5 years or so. And she said she would be reluctant to go back off of them as they help her so much. So yeah, again, that shared decision making, the benefit risk issues.
It is. It's different for everybody. I mean, it really is. And
even you, Patrice, too, with where you're at with your medications.
Yeah. So, I'm on an extremely low dose of prednisone. And when a doctor tells me, well, you should just go off of it completely, I just, without a game plan, and, I don't want to go back to where I was when I was first diagnosed. I lead a fairly active life. I mean, obviously I don't run marathons or snow ski or any of that stuff, but, I do walk 4 to 5 miles a day. And like I said, I'm able to travel overseas and play with my grandchildren. And so for me, it works. And that's probably where I'm going to stay. I'm not sure. I mean, who knows? We can't predict the future, but so that's my.
Yeah, I just think that's something that we definitely to report back to researchers and really, I think it's a great opportunity for our Rheumi rounds, for our AI Arthritis Voices 360 talk show. So one of the things that we have started, it's a pilot series, so we are going out and looking for funding for it. But the premise is it was founded by our organization and my rheumatologist, Dr. Kim. So if you've seen or participated or heard any of our talk show episodes, he has been on a few of them, and he is co-founding this with me. And the idea, again, it's called Rheumi Rounds, and the rheumatologist or rheumatologist professional, so that could be researchers, that could be nurses, and anybody in the field, come to the table alongside patients as equals, which is our mission. And we have conversations that normally wouldn't be happening in the office. So we're really kind of digging into the problems that we're identifying and sharing the other perspectives with each other. And so I think this would be a great one for to add to those pilot episodes of Rheumi Rounds, is to talk to some researchers about, and rheumatologists about, this topic with Treat to Target, what it means, the fear. I'm not sure that the fear element is fully realized. That's my takeaway from this, that it's something that they see because they saw it in the study, but the magnitude of the fear.
Yeah. I mean, truly,
it just can't be ignored.
Flaring, going back to where you were, losing mobility, all of those things factor in for sure.
I mean, and look, just the people who have been participating. I mean, nobody is saying, "Yep, I'm on board."
Save that money.
that just hasn't happened. There's something weird happened on my screen. My eyeball keeps disappearing. I just noticed that.
It's your glasses. Yeah. It's kind of where you're.
Well, I can't see. I'm blind as a bat. If I take them off, I don't have my contacts in. So.
Well, but I have contacts in.
But yeah, I've got some weird, like something's fluctuating with my eye. But in saying that, we have come to the end of our time, and I wanted to thank everybody who's tuned in, say Rosemary and Kim and Therese, and of course Deb and Patrice. And if you are tuning in and you haven't made a comment, that's okay. You can always still talk to us, and there's a really great way for you to do that. I'm going to tell you here about what that is. So we have this Go With Us to EULAR that we decided we were going to set up starting in June, because this e-Congress is available online to September 1st. And we thought, well, why don't we invite patients to go with us, and we'll try mixed methods of communication. So nobody's done this before. So it wasn't like we had any map or any blueprint that we could do. We just thought, let's try a lot of different things and see what people like, what works, what doesn't. And then we can build on this as we move forward to other conferences, which the ACR is online. So we'll be able to take this to the ACR and streamline it a little. So we decided in June we, meaning Deb, myself, and Patrice, went to all of the relevant sessions that we felt were important to advance the mission of our organization, to advance the things that we do as a nonprofit, but then, of course, would also relay back to our community. So we'd be able to help educate. We learn, you learn. That's always been our motto anyway. So this is part of that. We have the throughout July, we're going through and we're inviting you to the table to talk with us. Prior to that, on our YouTube channel, we also have 4 debriefs. So we talk about this, we talk about COVID, we talk about all of the sessions that we saw. So you can also see the debrief. So we have that way that you could sort of go with us. Then we have the next step, and this is the more intimate way to go with us. And so the people who have been signing up, which I see already on here. So tonight, some of the people who have signed up, the next step is to enter into our brand new AI Arthritis Voices website. And this is in a year and a half in the making. It's not like it's some elaborate, like bells and whistles site. I mean, we don't have that much money, but it is amazing because it houses everything we do as a nonprofit inside that site. It's not a support group. It's not a forum. It's literally a place where we continue the conversations like this, the projects we're working on inside, but it's private. So only people diagnosed or parents of juvenile patients can be part of this site. And we are inviting anyone who fits that demographic to go to aiarthritisvoices.org and click join. And there are patients who review the applications to ensure that we are inviting people that we believe are truly diagnosed with these diseases. We don't need any looky-loos in there. And then, and then from there, we have private activity pages. And those private activity pages are our projects we're working on that we want to have more intimate conversations. So there are some that are anybody who gets in there, they can see them. They're public. But this one will be private. So anyone who comes with us to EULAR, you enter there, we'll put you in the EULAR group. And then all through August, we're going to do more intimate conversations and watch parties and things of that nature. So it'll really be more of a go with us experience, and it'll help us figure out how we want to take this program moving forward to other conferences. So it's kind of exciting.
It's super exciting. So come join us and have a seat at the table and be part of the conversation.
My eyes, it's like I got a big hole in my eye. So yes, please do. We would love to have you with us. And again, just go to aiarthritisvoices.org and you can join if you are a person living with these diseases or a parent. And this is part of the EULAR 2020 series. So other than that, you could also check out all of our programs at aiarthritis.org. If you want to volunteer or would like to donate, we also have those options at the website. So we are always looking for support in various ways. So I think that's all we have for tonight. Yes?
I think so.
Okay. And then next week, we'll be focusing more on precision medicine. So we're going to build onto this. And then the last and final week, we will focus on pain. That will be the last one. So I want to thank everybody for joining us, and that's it. I hope everyone has a great rest of their day. And thank you for joining us at the table, because only as we gather around it together can we solve the problems of tomorrow. Your voice has